Welcome, everybody. We are so excited to have each of you join us today as we discuss the new Bree report on complex patient discharges. My name is Emily Noodleman, and I am the Transformation and Community Partnership Manager at the Bree Collaborative. And in my role, I primarily support the implementation of the Bree reports into practice settings. Before we jump in, I'd like to review some housekeeping items. You've all been placed on mute upon entering the webinar. During the webinar, there will be time after presentations from our speakers to ask them some questions. Throughout the webinar, please place any questions you may have and you would like to have asked to our speakers in the Q&A box located at the bottom of your screen. We'll not be calling on individuals to verbally pose their questions or comments to our speakers, rather using those questions that are written in the Q&A box. The webinar will be recorded, and we plan to send out the slide deck and the recording to you all via email after the event. The recording will also be posted on the Bree webpage for viewing. During the presentation, we will provide an overview of our organization and the report, hear from individuals representing different audiences within our healthcare ecosystem on how they intend to implement the guidelines in their role, and then we'll transition into that Q&A period. First, we just wanted to provide some background information on the Bree Collaborative. The Bree was created in 2011 by the legislation to bring together members from the different areas of the healthcare sector to address key health topics that impact Washingtonians by being a place for convening and collaboration. It was developed through House Bill 1311, and we really owe our creation to the leadership from Representative Cody and former Governor Gregor and others. We have about 22 members who are part of the Bree Collaborative, and they represent a whole host of different audiences within our healthcare ecosystem. So you can kind of see on your screen, we have public and private purchasers, health plans, delivery systems, healthcare professionals, QI organizations, a wealth of backgrounds in this. Each year, our members identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. These identified services serve as the focus for our reports. For most of the topics, we form a work group of subject matter experts and leaders to develop evidence-based guidelines. The guidelines take into account existing quality improvement programs and the work done by other organizations. Our reports provide guidelines for multiple audiences, such as clinicians, health delivery systems, plans, purchasers, and others, not just those that we were listed that are representative of Bree members, but others as well, like public health agencies, to encourage collective action to promote optimal health for Washingtonians. To date, we have over 40 plus reports, and this past year, we developed reports on complex patient discharges, diabetes care, and perinatal behavioral health. And in 2024, we are working to develop reports on health impacts of extreme heat, behavioral health, focusing on early interventions for youth. And we're revisiting and updating a former report that we developed on treatment for opioid use disorder. The Bree Collaborative forms work groups to bring together individuals across the state to engage in providing their expertise to help craft the report. We greatly appreciate our work group's members' willingness to share their time, knowledge, and expertise with us. And today we look forward to hearing from some of them and sharing the report with you all. We hope by the end of this meeting, you will leave with a greater knowledge of the Bree Collaborative and the report on complex patient discharges, learn more about collective action to support people experiencing a complex discharge in Washington State, and a deeper understanding of what different audiences within our healthcare ecosystem can do. You've already heard me kind of say these two words, Bree report and a Bree guideline. We just wanted to provide some grounding information on what do we mean when we use these terminologies. So first, a Bree report is a multi-page document on healthcare service identified by Bree members as needing improvement that provides information and guidelines of actions different audiences can take within the healthcare ecosystem to improve the healthcare of that chosen report topic. We do focus our work within Washington State, but the report could be used by other states to inform their work as well. We use the term Bree guideline, a Bree collaborative guideline, which was previously referred to as recommendation in our earlier reports, are actions to be taken to improve healthcare for specific healthcare services. Today, you'll hear both about reports and some of the specific guidelines as it relates to a patient experiencing a complex discharge. So during the majority of our presentation, you'll get to hear from some of our work group members. Our speakers are Darcy Jaffe from WSHA, who is a Bree member and was the chair for this work group. She'll provide information and an introduction to the report and the data on complex patient discharges in the state. We'll then hear from Zosia Stanley from WSHA, who will provide the hospital perspective in this work. And then Kelli Emans from DSHS will review how DSHS can support patients experiencing a complex discharge. Another key audience who we were unfortunately unable to have the capacity to have join us today are health plans. However, we want to recognize they are a key partner in supporting complex patient discharges and are an audience written for this report. And again, after that mini presentation, we'll have a Q&A, so please let us know any questions. And I will pass it off to Darcy.
Great, thank you, Emily. And welcome to the webinar. We're very excited to share the work of the work group. And so let's get started. Next slide, please. One of the important features of the Bree is that every year we have multiple topics to consider, and we have to decide how many we can approach in a year, technically, or usually about 3. So why did we select complex discharge for the Bree? Well, there's a lot of different reasons. First and most important is patient health outcomes. For patients who are stabilized in the acute care phase of their health condition, to be in the hospital past that time puts them at risk for hospital-acquired condition. They don't have access to the kinds of post-acute care care that they need. And in general, it's just, I'm from a hospital. We love hospitals, but if you don't need to be in a hospital, it's better not to be in a hospital. A workforce burden. We know that our healthcare workforce and all different kinds of staff and disciplines are stretched. And to have the staff taking care of patients who no longer need to be in the hospital doesn't give them the opportunity to care as much for the patients who are still in the acute care, the critical care phase of their illness. Hospital capacity. This is a very significant outcome of our challenge that we have here in Washington and across the country. Because patients who are in the hospitals waiting for post-acute care stay in the hospital far, far longer than the average length of stay. It's not just the bed that they're in, and what they're doing often is they're in the bed that several patients, 5, 6 patients could have been able to be cared for in that bed over the course of the time that they're in the hospital. Additionally, it trickles down to our emergency departments, which is one of the major causes of our ED boarding that we have in our state. And then finally, there is financial strain on the hospitals. Once a patient is finished with the acute care portion of their stay, the waiting period is very seldom is it paid at the cost of care. And so this really continues to strain our Washington hospitals, all of whom are still recovering from a lot of the pandemic, and many of them are very tenuous in their financial situation. Next slide. So, as I said, this is not just a Washington problem. This is a national problem. In a recent study from the American Hospital Association showed that between 2019 and 2022, patients waiting for discharge had an increased length of stay of almost 24%. And that when they do their CMI, so case mix index adjusted length of stay, so that accounts for their acuity, then the length of stay still was more than 20%. And they showed in the report, and the link is here for you to look at in more depth when you get the slides, that the acuity of patients who are waiting for discharge is also increasing. So there's so many factors that are in the way of patients being able to get their care in the right place when they're at the right time. One of which is that we're asking our post-acute care partners to take care of a much more complicated and a sicker patient. Next slide, please. So WSHA did a survey. We survey our hospitals on a fairly regular basis to get a pulse of what's going on. Our most recent survey in January revealed that we had almost 1,000 patients in Washington that were in the hospitals waiting for discharge. And then over half of them were waiting for skilled nursing facilities or adult family homes. There were a few waiting for psychiatric hospital, a few waiting for home health, but really the majority of them were waiting for that more high level skilled nursing or adult family home care. And for more than 61% of the time, patients were actually admitted from home. And so these are patients that can't go back home because of their health condition, or they lost their housing while they were in the hospital. So that we really, there is some thought sometimes that patients that are waiting for skilled nursing homes or adult family homes are admitted to the hospital from unstable situations, but that's not necessarily what we're seeing. The length of stay for patients range from just a few more days to more than 6 months, and more than 30% of them are waiting more than a month to be discharged. So with the average length of stay in Washington for acute care being 4 to 5 days, if we have patients waiting 30 days, then that extra, 25 days, that could have been 5 patients who could have been cared for in those beds. And we know that Medicare and Medicaid was the payer for over 80% of the patients. So this is managed care Medicaid, fee-for-service Medicaid, Medicare Advantage, and then traditional Medicare. So public payers for most of the patients. Next slide, please. So when we were looking at this, initially, and many of you may have heard difficult to discharge to be a descriptor of the population that we're looking at. As we came along and had more conversations with each other, we just didn't feel like that was the right description, and that we did change the description to complex discharge, because it really although sometimes it's patient characteristics, mostly when we really looked at what put a patient into these categories, there were a lot more systems issues than there were patient issues. So we decided, what could we do? This is such a big problem. One of the things that we right in the beginning decided is that guidelines were not focused on things that the players in the healthcare ecosystem don't really have control over. So we weren't going to make recommendations for the federal government to change the way they do Medicare funding, for instance. So we weren't going to really look at policy issues. We wanted to focus on those areas where hospitals, where Medicaid MCOs, where post-acute care providers really could make some potential changes in the way that they were doing processes to at least help a little. We knew these guidelines aren't going to fix the problem in total, but this could make it better. So we adopted a common definition, and some of you might be thinking, well, that should have been pretty easy. But honestly, one of the other early indicators that we had was that we have a hard time collecting data to get a really good sense of the problem. And that's because across the ecosystem and within different factors within those ecosystems, hospitals might have the definition different, MCOs might have it different. So we worked really hard to come up with a common definition. We looked at, could we come to agreement about what defines someone with a complex discharge situation? Can we come up with some common characteristics that would have someone put into that category? So we really worked a lot on that. And then how do we record the discharge barriers? Is there a way to standardize how hospitals are doing it, how the health plans are doing it, so that we can have some common conversations and have the same language? And then finally, a lot of guidelines and recommendations of how to work on coordination and communication between acute care, post-acute care, our public agencies, and our health plans. This is, I will tell you that in the work group, and maybe Zosia and Kelli will talk about this as well, I have been working with the complex discharge patient populations for decades, honestly. And this was probably one of the first time I've really seen a work group that had representation from people that work across the ecosystem. And it really was very interesting. We were able to pull together and pull out information that maybe one area just really wasn't aware of. So this was a great opportunity, and I really appreciated the, I appreciated the participation and the honesty that came in the conversations that we had. All right, next slide, please. So I talked about a common definition, and then this is the definition we agreed on and that we are recommending that everyone across the healthcare ecosystem use when we're talking about this population. So patients who are medically ready to be transferred outside of an acute care setting, but are unable to do so due to discharge barriers. That might seem pretty straightforward, but when we got done, we realized it was quite a process to get there, but this was a good conversation to have. And if we can have some agreement that this really is how we are going to define the population, we will have we'll have more success in looking at the picture, at having communication and conversation. All right, next. We also spent a lot of time coming up with some standard terminology and standard barriers that were that place the patients and made it much more complex. And you can see the list is really long. It's and if there are those of you in the audience that do this for a living, there probably won't be anything on here that surprises you. But what we really wanted to do again was standardize it so we could collect information so that we could have conversations that we're all kind of talking about the same thing. And we also recognize that for most of our complex discharge patients, they have multiple discharge barriers. And so this list would have many, many check marks in the when we're looking at the patients, whether you're the payer or you're the provider. And this is in the in the recommendations, and I saw that there was a link to the recommendations put in the chat for you to access. Next, please. All right, so as Emily said, we had, and I've said we had a lot of, we had participation and representations from multiple hospitals, health plans, DSHS, post-acute care facilities, adult family homes, and assisted living. It was a combination of, we had physicians, we had social workers, nurses, all kinds of people that are involved in the complex discharge population. It was a great opportunity to have a really robust conversation at each work group meeting. And today we're going to really focus on the hospitals and DSHS. Okay, next. All right, and now I'm going to hand it over to Zosia Stanley, who is one of my colleagues at the Hospital Association, who works very day-to-day in this field, and she's going to share with you some of the guidelines that we came up for the hospital. Take it away, Zosia.
Great, thank you, Darcy. Good afternoon, everyone. I see on the attendees list lots and lots of folks that I know who are engaged in this topic from various parts of the system. So thank you all for joining us today. As mentioned, I'm Zosia Stanley. I'm the Vice President and Associate General Counsel at the Washington State Hospital Association. Next slide, please. And pleased to be involved in the Bree's work. Before jumping into the guidelines, I wanted to start with a little bit of orientation towards the larger topic, which I know that you all are all familiar with, but I find that this graphic from the Northwest Healthcare Response Network is a nice grounding, right? And I like this view, and I really appreciate the networks putting this together and letting us use it, because I think it does a nice job of pointing out the challenges that are felt by various parts of the system, right? Long-term care has challenges when it comes to rate and workforce and accessibility. EMS feels the pinch if they are not able to move patients between settings in a timely manner and discharge them. For example, if they're there's called wall time, right? If EMS can't get a patient out of an ambulance into a hospital ER or another setting because of some delay that is really felt by that part of the system, they're not available to go do the rest of their job. For hospitals, we continue to see, some real challenges when it comes to ER capacity, acute care inpatient capacity. As Darcy noted, if we have an average length of stay of 4 to 5 days and we have patients who are staying 30, 40, 60, hundreds of days, that backs up the system. And then, we have the challenges when it comes to primary care settings, when it comes to workforce and kind of people needing more challenges getting care or getting scheduled. And all those pieces of the system are interconnected. And one thing I like about this diagram is that illustration, right? That there's no one part of the system that owns the entire thing and thus can make can make one change, one ring to bind them all, and in the power, and actually make that change. So each part of the system is feeling its own specific pain points. And the commonality is that we have patients in all these places who are either not getting access to the care that they need in a timely manner, or are not able to move to the next care setting, and that impacts our patients and our family members and our communities and access to care in all these settings. So I like this image for that. The other thing I want to point out, right, is but for the hospital perspective, and again, we are just one point in this ecosystem, as Darcy said. We are the point of the system that has an open door because we have EMTALA obligations under federal and state law, meaning we will accept all comers and screen and stabilize, but we don't have a lot of control over the back door. So the opportunity to move patients out into the next best care setting, whether it's home with home health, to a skilled nursing facility, a nursing home, an adult family home, assisted living, the whole panoply of potential next settings, we often don't have that power to make that happen in a timely manner. So one of the things to think about with these guidelines is that these are, and I'll get to this in a little bit, the guidelines are an opportunity for hospitals to identify which parts of the process that they can own and control and identify for themselves as an opportunity without the need for external changes, which we'll also talk about. So next slide, please. So I want to acknowledge the many parts of state work that have been going on in this issue over the last many years. For the Hospital Association, and I think I started with this, but we represent all the hospitals in the state of Washington, right? So that means we have large healthcare systems, public hospital districts, critical access hospitals, behavioral health hospitals, independent hospitals. So, a wide array of providers. This issue of complex discharge has been a priority for us since about 2016, which feels like a very long time ago. Anything pre-COVID feels like a very long time ago, but we have been working on this for that amount of time. We have made progress, but there's still a lot of opportunity here. It is a target-rich environment for improvements. I want to, though, acknowledge, in addition to the work that WSHA has done, there is currently a governor's task force that the legislature stood up on complex discharge. It has started meeting over the summer and will meet for the next couple of years. And a big part of that task force is to set up a 5-site pilot across the state to test out the use of ECM. And I never remember what that acronym stands for, but inherently it is enhanced services to wrap around complex patients to hopefully allow long-term care to accept more complex patients who would otherwise be waiting in hospitals. So that pilot should be standing up April the 1st, and we are going to hopefully begin to see data coming out of those pilot sites around, what are the rates that are being offered, what are the most common barriers to discharge or patient complex needs. And we hope that work then will lead into some funding for the legislature to expand funding and opportunities. I want to acknowledge the Bree Collaborative's work. WSHA has a complex discharge work group. I see lots of members of the work group representing most of our hospitals in the state. I also want to acknowledge a lot of work by DSHS, the Department of Social and Health Services, the Healthcare Authority. Both of those state agencies, I think, have done a lot of digging in on this issue of kind of what are the pieces what part of the elephant do they touch? What pieces that can they look at? I think a lot of data, and I know Kelli will talk more about this, has been very helpful from both those state agencies on kind of how to address the barriers we see. Also, I know that carriers have been talking about this a lot around kind of, utilization management and oversight and process. And the long-term care associations have also been very good partners, working with, together and with others, and trying to identify how can we expand our capacity to serve patients in long-term care. Next slide, please. I like this next slide because it is a visualization of what this issue can feel like, where it is a lot of moving parts, right? As we talked about, there are payment issues, there's patient characteristics, there's system barriers, there's lots of pieces here, and it can feel like boiling the ocean. And one of the things that we did in this Bree collaborative discussion, as Darcy mentioned, was to have an array of folks who are coming from different parts of the system to come together and say, these are things that I see commonly, these are the barriers I see, this is the communication problems that I experience, and I'm talking to other parts of the system. And I think that the guidelines in the Bree report help to kind of narrow in the world here instead of just feeling like this is really hard, and it is really hard and it's really challenging and there's so many parts of the system involved, but narrowing in on what are the opportunities that each of us have or each of our entities have to really focus on the pieces that they can own and make the processes better for patients and for themselves. So next slide, please. So getting to the guidelines for the hospitals, this is just the first page. I think the hospital guidelines are 4 or 5 pages long. I pulled out this one because I think it is helpful to kind of just see what the basic structure is. And I wanted to make a couple points around kind of the usefulness for these guidelines. So one is these are foundational, fundamental kind of best practices that hospitals can assess and adopt. I know lots of hospitals are already doing pretty much everything on the list and potentially more. Some hospitals are doing parts, but not all. And I think these guidelines can function in a couple ways. So one can be a process check to say, what is my hospital currently doing? What are the pieces here that we are, totally great at? We're all over it. We've got it dialed in. Versus what are opportunities where we see a pain point? Is it that we have a real challenge when it comes to DD patients who get stuck with our hospital and we don't have a good communication line with DD within DSHS? Are there pieces of this document you could use to kind of put those communication structures in place? Another opportunity to think about is how are you collecting data on complex patients in your hospital? Because most hospitals will have data on the number of patients that are stuck or have been stuck in the last year, or the length of time, average length of time people are waiting. But oftentimes that data is not, either you can't compare year to year, or it's hard to pull that data out and make it comparable with other hospitals, or even hospitals within a system can have challenges in making sure that their data is comparable. And I know that many of you who are from hospitals are well aware of this work and the importance of this. And having the data is very helpful to then understand, the basics, right? Who's getting stuck? Why are they getting stuck? Where are our pain points? The other thing I think that this tool can be helpful with is communication, both internally within a hospital, to say, because I know that there can be challenges with, someone in the hospital saying, what is happening? Why do we have patients who are stuck for such a long time? And this communication tool can be helpful in saying, this is the list of potential opportunities we have. This is the pain point we see. Let's focus on this and see what it is we can do to either, gather additional data, have better internal training, more communication, whatever it is. The other thing I think that this checklist can be helpful on is using it as a communication tool with other parts of the system. Because there is a guideline for hospitals, for state agencies, for carriers, for long-term care, I think there is a real opportunity for a hospital to have looked at its own checklist and say, these are the things we feel like we're good at, these are the things we are working on, these are the opportunities, and then have a conversation with a long-term care partner or a carrier to say, have you all looked at the guidelines that are specific to your entity? Where do you think you are? What's your perception of how things are going? And I think that this is potentially an opportunity for those communications. The other thing I would flag here is that, and again, kind of on that data piece, there are continuing opportunities, and we'll talk about this in the next slide too, around sharing data with state agencies or with carriers so that you can all be on the same page once you've gotten that kind of common definition. Do you have a common way that you are measuring when patients are stuck, when they are in a complex discharge patient where they should be? So next slide, please. So I pulled out this other piece of the guidelines for hospitals because this is specific around the communication referral with DSHS Home and Community Services. And I know Kelli will talk more in depth about this, but I wanted to pull this out to specifically kind of walk through what this piece of the recommendation, the guideline is. I do a lot of conversations with hospitals. This is a part of my job I really enjoy, is talking to hospitals who say, I'm finding this pain point in communication, or I have this patient that I can't figure out what the next step is. What do you recommend? And when it comes to HCS, there's often some very kind of structural fundamental pieces that are really helpful for the hospital to have done to then be able to be on the same page with HCS. Things like clearly indicating, and they're pretty basic things, but clearly indicating on the referral form for HCS assessment whether the patients in the hospital are going to be in the community. If possible, establishing an agreement for HCS to have access to some portion of the EHR to get that patient information, which really helps with the assessment. I know most hospitals in the state have that. Regular meetings with HCS regional staff to talk about where things are, because then that opportunity is to then have an ongoing relationship and communication pattern with the agency so that it's not a one-off trying to find who the right person is. So I do commend these, and there's this process piece, I think, also exists for DDA within the recommendations. So I do commend these pieces to you. And again, some of you will say, this is absolutely what I already do, and you are on the right track. And there may be some elements that would be helpful for you all. So I think that is it. I'm going to turn it over to Kelli next, and welcome any questions now in this conversation, or feel free to follow up with any of us on this call. We're always happy to talk more. Over to you, Kelli.
Great, thanks, Zosia. Okay, well, good afternoon, everyone. My name is Kelli Emans, and I'm the Senior Strategic Integration Advisor for Home and Community Services, which is a division within the Aging and Long-Term Support Administration of DSHS. And I love following Zosia and Darcy because I know they're both passionate about this work, and I am as well. I'm going to spend a few minutes discussing the role of DSHS in transition work, what we at HCS specifically have been doing to improve our system and approach to complex transitions. And then I'm going to touch a little bit on how we're using the Bree collaborative recommendations to further our efforts. Next slide, please. Okay. So many individuals who enter a hospital may never need the services of DSHS, but for those who do, both Home and Community Services and DDA play a critical role in helping to transition patients out of the hospital. Usually individuals that are referred transition seamlessly to the community with the assistance of DSHS, who helps them, individuals by determining eligibility, developing a person-centered care plan, identifying transition options, and ensuring that services and supports align with the client's needs and preferences. And then we also work with our system partners to address any medical or behavioral health needs. That said, we know that for individuals with complex needs, things get a little bit more tricky, particularly in the time it takes to navigate the barriers to transition to the community. And in these cases, the assessment is often not the key piece here, but addressing all of the barriers to allow that individual to transition back to the community, especially for individuals who present with significant behavioral health needs, in addition to any medical complexity. So next slide, please. All right. So this slide, I think kind of like Zosia said earlier, this slide represents work since 2017 that we have been doing to address the complex discharge issue. And this is not new for HCS, like it is not new for hospitals. And it shows the continuous improvement that HCS has been engaged in to meet the demand, particularly as our system serves a more diverse and increasingly complex population that also have co-occurring behavioral health needs. I would also note that we've been aided in this work by investments from the legislature, both in staffing and new programs, as well as collaboration from our system partners. Next slide, please. So the last slide shows some of the work that we've been engaged in for the last few years. This slide shows from 2020 to current the statewide average length of stay for hospitalized individuals. So for all the work that we've been doing, we are seeing progress. This is the average length of stay over the past 4 years. The average length of stay started at around 57 days, which is, as Darcy and Zosia spoke to earlier, of course, much longer than our hospital partners would like to see.
Kelli, I think we may have just lost you for a minute.
Significant reduction in the average length. I would also acknowledge that, but a lot of this, yep.
Okay, there you go. It
I'm here.
short circuit. Okay, great. Now we can hear you. I'm sorry. It just needed a
Okay,
minute. You were talking about the an average length of stay being longer than people had hoped. That's where it cut
Okay,
out.
so average length of stay was longer than people would like still. So I think where I may have paused was the reduction in the average length of stay from 57 days to 32 days. And just acknowledging that that was is longer than our system partners in the hospital would like. We've achieved this by reducing our longest length of stay patients. While at the same time, we're continuing to receive nearly 500 referrals a month from acute care hospitals. Next slide, please. So throughout all of the work we've done over the years, one of the key themes has been increased communication and collaboration. This theme has come up in nearly every venue where we discuss this topic. And I was pleased to see this theme continue to play a big part in the Bree collaborative recommendations. And this kind of highlights what we already know. And that's that all the systems of care have to come together and make changes if we want to address the challenges we collectively face to serve people stuck in hospitals. So we are invested in this work, and I was particularly excited to participate and represent my system in the Bree Collaborative. What I will say is, as Zosia kind of went through the recommendations, DSHS, both HCS and DDA, had a lot of recommendations. But I was thrilled to see that many of them aligned with work we've been doing for the last several years and are already committed to. So if you look at the top of this slide, I kind of pulled out two of the Bree recommendations, which were to flag clients in our system that are experiencing complex discharges, and then to develop care plans in collaboration with system partners. This is something that we identified early on. I think we really started doing this work during the pandemic when we were seeing such high volumes of individuals in the hospital. One of the first things that we did was work to establish regular coordination with our hospital partners. By having regular meetings, we were talking about who was on their list and who was on our list. And then more recently, we started having conversations with hospital partners to bring our managed care partners to the table as well. Having all three of us at the same table, having the same conversation, we believe leads to more timely transitions. We also established staffing processes internally, so both at our regional level and at our headquarters level. A lot of these cases are very complicated. As Darcy mentioned, they will have multiple barriers to transition, and often it takes out-of-the-box thinking. It takes cross-system coordination, and sometimes getting leadership engaged from across the different systems of care. Another thing that we've experienced in our work doing cross-systems coordination is that we speak different languages. Often when we're trying to coordinate, you're coordinating with a system that has very little knowledge of what you do or what your system does, while at the same time, you may not have that much knowledge of what they are doing. So we've done some work to establish regular points of contact with our managed care partners and with our regional staff, so that we're helping to have those conversations across systems of care and bridging that coordination and communication gap when we think we're asking a question that makes sense to our partner, but maybe we have a different shared understanding. So far, by implementing cross-system coordination and escalation paths, we have continued to see reduction in our longest lengths of stay in patients, and we've seen improved communication and coordination with our system partners. Next slide, please. So the last slide here is about implementing one of the Bree recommendations, and I smile about this one because it seems pretty simple after all of the work that we've been doing to coordinate across the systems. And the recommendation was that if we escalate cases internally, that we should escalate with our hospital partners as well. And this was kind of an aha moment. We had all the tools to do this. I just don't know that we considered that they may want to have the same awareness of the work that we were doing. So we already had done some work with WSHA to get escalation contacts from hospitals. We were already sharing escalation contacts with our hospital partners. But after the recommendations came out, we implemented a new process in January where if we escalate the case internally, if it's come to our headquarters level, then we also send a message to our hospital partners, the escalation contact, letting them know that we have escalated a case and asking for their support in ongoing conversations. So far, this has been met with appreciation. I've gotten emails back from hospitals happy to know the work that's happening and also making offers of what assistance could they provide to help move things along. So I think my takeaway from the collaborative was that although we've been invested in making progress within our system, there's still a lot of stuff to do. And this is a process for continued improvement, especially as we have seen the populations get more and more complex over the years. I really appreciated all the voices from across the continuum that lent their expertise in this collaborative work. And I just wanted to end thanking everybody for giving me the opportunity to share some of the work we've been doing.
Thank you so much, Kelly. We will now transition to the questions and answer portion. I'll invite the speakers to come off or come back on their camera, and I will stop sharing my screen so we can see everyone. As you were all speaking, there was a couple questions that came in that were about specific populations and if they were included in the report and how they may be included in the report, or just if they were even discussed during the work group process. One was more on rural health and how rural patients who are not medically ready for discharge, who need higher level of care that seem to be often less extent, resulting in more poor outcomes at times, and kind of what was happening if a conversation about rural health was had during this work group, and additionally another one on complex pediatric patients if they were considered during our work. From my knowledge of our report, we tried our best to kind of make the guidelines as broadly applicable as possible. But I wonder if Darcy, if you have any additions to that or anyone else.
Well, that was the first question. Did I hear it correct that it is patients in rural hospitals waiting for higher levels of care?
It said rural patients who are not medically ready for discharge who need higher level of care that seem to be often less available.
Yeah, no, that was not part of the scope of this particular work group. However, indirectly, we do hear that some of the delays in being able to transfer patients are a result of the larger hospitals not having capacity. And a lot of those capacity challenges are related to the complex discharge patients. So it's an indirect impact, but we didn't talk specifically about the population that the questioner asked about.
Yeah, this is Zosia. I would agree around that kind of the throughput challenge, right? If your larger hospitals don't have the capacity, you can't get the rural hospital, the rural patients in. And to your point, I think we did focus on kind of the broadly applicable nature of the guidelines. We did, and I think there's a question around kind of pediatrics specifically. I don't recall our conversation really pulling apart the kind of adult versus youth or adolescent populations. I will say that I know that all of our populations face complex discharge issues, right? I know we get pediatric patients who get stuck. I think the other piece I wanted to add on the rural side is for rural specifically, right? more challenge when it comes to if you're in a rural healthcare setting, you have even more limited community capacity for long-term care. So we know that that's one of the challenges for some of our rural healthcare providers is kind of in an urban setting, you at least have more kind of opportunity, more potential partners, and some of our rural settings just really don't have a lot of options that are local that people would want to go to.
Yeah. I'm kind of curious, what is one change of practice do you hope to see occurring by an organization utilizing the report on patient complex discharge? If you could pick at least one. I know we highlighted there's quite a few guidelines in the report. I'm kind of curious what would be something that, if you could pick one of them that really stand out to you.
I'll pipe up. I mean, one for me, I think is common discharge barriers, I think would be really helpful. Sometimes when we're talking about trying to solve problems, if we have different definitions of what the barriers are or where the pain point is, it's harder to solve for the problem. So I really liked the discharge barriers, breaking it down by process and actually breaking those processes down, and then breaking down the other discharge barriers as well. So we can kind of pinpoint more where the issue is and work towards solutions.
Yeah, I think building off of that, for me, part of it is that data is having good data, so that to the point that Kelli was kind of raising, if you're saying, you know, I have 50 stuck patients and that's really challenging. When you can say I have 50 stuck patients and, you know, half of them are waiting on a Medicaid patient waiting on an HCS assessment, or this portion of them are actually a DD patient. This portion is actually Medicare Advantage because the inflection points are going to be different depending on the payer, and then also depending on what is the barrier that you're seeing that patient needs. And so having that data that's, you know, easily comparable across within your system, easily comparable or shareable externally, somewhere kind of to show your work to other partners can be helpful. Because I think sometimes that has been a challenge in the past where the hospitals say, oh my God, like I have so many stuck patients. And I know from like HCS's perspective, sometimes there's well, they're not all HCS patients. So if you bring me a list of 100 patients and half of them are not patients that I can help you with, that's not going to be satisfying conversation. So I think having that good data to be able to really quickly see who you have now, who you've historically had, what impact has been useful. Those would be my pieces. What do you think, Darcy?
Oh, I completely agree with both of you. And it occurs to me that one of my learnings in being in the work group was to better understand some of the processes of the other partners in the system. So I think that even if wherever you are, payer, provider, state agency, post-acute care, if you looked at the guidelines and of the partners that you're not, so if you're a hospital, if you look at the MCO guidelines and you get a better understanding of what their processes are, and then take a look at how you might partner with someone, you know, what makes more sense with new information that you've learned.
Another question I have is, after supporting the creation of this report on complex patient discharge, what about the report do you personally feel most proud of?
I think it's been talked about a couple times, but I think the two pieces that I would flag is one, that common definition, which again feels like very low-hanging fruit, but the opportunity for each part of the system to have at least a beginning common definition about the population we're talking about. It's actually a pretty good step to kind of, again, find that kind of common ground. I think the other piece is having a common document to refer to for different parts of the system. I think in the past, there's been a lot of kind of compartmentalization of various parts of the system, saying this is what we've talked about internally in our part of the system. This is what we think it is. So it is helpful to have kind of a standard tool to, as I said, to use for those communications.
Yeah, you know, I actually like that we changed the name from difficult to discharge to complex discharge. I think that, you know, there is a lot of stigma attached with patients that have a lot of these barriers. And for our mindset to start to think about this as a system issue and not necessarily an individual patient issue, I think that I'm really proud that we had that conversation.
Yeah, I second you, Darcy. I think along that same line is like, yes, there are complex characteristics of patients, but it is actually barriers within the system that is creating them not being able to transition to another level of care. And so I think for me, one of my favorite parts of this work was having everybody at the table, having that conversation and acknowledging how critical it is that we talk to each other, and that we learn the different pieces of the system, because I think that then leads to less finger pointing and more collaborative discussion. So this is hard, and it's going to take us all to try to solve this.
I think it's interesting that you kind of bring up the system. There's a question that was posed so kind of the Bree guidelines are really talking about how can we develop new processes or kind of change some current processes to work collaboratively across the healthcare ecosystem to improve complex patient discharge. They're just kind of posing, if the system is not working for us, how other ways can we change the system rather than just changing processes? Or do you think that's the way to do it? It's kind of a big question.
I'm going to take a little stab at it. I think it goes back to what Zosia said about data, right? Too, is that like to change the system, you have to be able to tell the story and present the data. And I think the effort here is to try to get on the same page about the data we're collecting to better tell the story to change the system, right? So that's, I guess, would be my response. I don't know, Darcy or Zosia.
You know, my thinking about it is I agree that even fully implementing the guidelines, we'll still have patients that are waiting for discharge because there are a lot of external, environmental issues that are beyond the control of all players right now within the ecosystem. However, there are still opportunities for us to make it better. I think it's really easy to get discouraged and to, and to just think that we need a whole bunch of we need the government to fix things, we need Medicare to work, but all those sorts of things, which probably we do. However, if we can really focus on where do we have some control to make things at least a little bit better, we can, we'll be doing a better justice not only to the patients, but to our community as well.
Yeah, I think there is that kind of think globally, act locally aspect to this as well, of kind of to the point, right? None of that graph that I shared, right? No part of the system owns the entire system. I do think that there are opportunities to work at that higher level, and some of the work that I know DSHS and HCA also have advocated or provided information to the state on kind of what funding would look like to address specialized services for certain populations that get stuck. WSHA has done a lot of advocacy with the state. And I think Darcy's point is a good one. You can't always look to somebody else to solve the problem. You have to, figure out the pieces that you own as well. But I think there is some collective work that we have all been able to do together to raise this into the consciousness of our elected officials in our state, to say this is an ongoing problem that actually, deeply affects individual human beings who get stuck in hospitals unnecessarily. And so I do think that there is this opportunity to continue to work at all the levels. There's no one fix, but if we continue to work at all these levels, I think we can continue to make progress, even with the ocean of issues that we have.
Yeah. Well, thank you all. I'm just looking at the time. Zosia or Darcy, if you have the capacity, there's a couple of questions in the that were just posed asking specificity of if something was talked about in the guidelines. I didn't know if you could say yes or no, and if no, point them to a resource if you have that capacity, or I can send them out after too. We just want to, in kind of a wrap up today, we have posted a post survey in the chat. If you wouldn't mind filling that out, that would be great. We also just have some upcoming events that we would love to invite everyone to participate in and join if you would like to. First, here at the Bree Collaborative, we are going to host another cohort of our Health Equity Action Collaborative. So if there is a guideline that you heard today that you are really passionate about and would like to develop a project plan around and receive some support on quality improvement and grow some grow in quality improvement skills and kind of develop and work with these partners across the healthcare ecosystem to develop your project plan, please join us at the Health Equity Action Collaborative, and you could just email us for more information. But the idea is that you take one Bree guideline from a report and work to help develop that with a plan within your organization. Participants pick different guidelines from any of the reports that we have. And we really meet each month to help develop those and grow together. It's a really great space in making sure that we're centering health equity within those designs. Additionally, we do have checklists. So I think it was Zosia was highlighting how the guidelines are listed in a way that's kind of like a checkbox. So you can kind of do a self-assessment of what have you done so far and where do you need to grow. We worked with our work groups to develop a checklist of levels 1, 2, and 3, where they have provided insight on kind of the level of perceived difficulty to implement some of these guidelines. So if you would like to use those are on our website. And we also, based off of how people are doing on implementing our guidelines, we want to provide awards and recognition for all that hard work that it takes to really implement this work. So we have information online for that as well. Just in closing, again, this webinar is recorded. We have some other, and we will send out this recording in the next couple of days. Next week on Wednesday, March 6th, crazy, it's almost March already, from 12 to 1:30 p.m., we are going to host a webinar that in collaboration with Washington Health Alliance and Comagine Health, focusing on value-based payment and health equity and kind of the intersection between those and how we can center health equity in this value-based era. On Wednesday, April 24th, from 12 to 1:15 p.m., we're hosting a Learning Lab webinar focusing on connecting with Latino communities on diabetes care, where Dr. Leo Morales will be joining us and presenting. These events are open to the public and free, so we'll put some links in the chat if you'd like to join us. But we just really want to kind of spend the last couple minutes of this webinar thanking our presenters and our speakers and everybody who joined us today for your participation, and also everybody that participated within our work group. They provided us with their time, knowledge, and expertise, and we could not have made this report without them. So we are very grateful for everything. And we are grateful for each of you joining us today. And we hope to stay in touch with different events and offerings we may have around this topic. But with that, I hope everybody has a great LEAP day. Thank you for joining us.